retinopathy, and now I invite Dr. Kim. He will be tackling on the systemic parameters and their management. Dr. Kim.
Thank you, Dr. Ajit. We all know the problem of diabetes and diabetic retinopathy in our country. With 101 million diabetics, we have a huge problem. This was a study, Raji Raman led study, that multicentric study that we did sometime back under Smart India label, where we found the prevalence of diabetic retinopathy across the country, done over 10 states, showed the prevalence was about 12.5% with the vision-threatening diabetic retinopathy at 4%. Why this? Because the numbers are huge for every one of us to be aware of what diabetic retinopathy means to as ophthalmologists and what do we do about it. So I'm just touching upon the systemic parameters and how it impacts diabetic retinopathy. We have the modifiable factors and non-modifiable factors. Modifiable like the sugar, blood pressure, cholesterol, obesity, and many other things. And we have enough data in the literature to show the impact or the effect of these parameters, such as the blood glucose, blood pressure, to show how important or what is the role that it plays in the development of diabetic retinopathy. So duration of diabetes, we are all aware of. The longer the diabetes is with the patient, the more the chances of developing diabetic retinopathy over a period of time, even if they have a good systemic control. Gender, again, the higher frequencies for proliferative diabetic retinopathy is present more in men than in women. It was shown that it increases with age. Of course, the DCCT, UKPDS, and all that have shown that intensive glycemic control, how it can reduce the HbA1c and thereby reducing the progression of diabetic retinopathy to the advanced stages. Chennai urban study had shown that every 2% elevation of HbA1c, the risk of diabetic retinopathy is increased by a factor of 1.71. This study done by Mohan's group some time back to study the relationship between the regularity of follow-up and risk complications in patients with type 2 diabetes who were followed up over a 9-year period. They showed that when patients were regularly followed up, they were associated with significantly lower glycemic burden and lower incidence of retinopathy and nephropathy. So what it means is, how much do we as ophthalmologists take care of the patient's the control of diabetes? Most often we would ignore that or do not pay attention to that part of it, except when the patient brings the blood sugar values and you say, oh, it's very high, you need to control. But do we monitor it? So we all know this data that even if there is 100% control of diabetes, there's still a 25% chance that the patient may develop any retinopathy. But the more important factor is that there will be a reduction in the progression to the advanced stages of diabetic retinopathy if they have a good control. Glitazones, the drugs, anti-diabetic drug, they are associated with an increased risk of diabetic macular edema in patients with type 2, especially in those undergoing insulin therapy. And then semaglutide, the drug which is now used for many people, especially they even use it for obesity reduction. The SUSTAIN 6 study had shown that there is a 76% higher risk of retinopathy-related complications in patients taking semaglutide as compared to placebo. Focus study, we are one of the centers. There are multiple centers, about 16 centers in India. It's a global study across happening. Just the focus studies, whole purpose is to understand. It's a 5-year follow-up of diabetic patients taking semaglutide and those on other drugs with controls to see if semaglutide is causing any progression of diabetic retinopathy to advanced stages. So this study is currently ongoing, but the current advice is to be using this drug in patients with pre-existing diabetic retinopathy. You have to monitor them very closely because there are signs, there are interim reports that keep saying that there is the effect of semaglutide is worsening diabetic retinopathy. But that the end results have to show that or confirm that. Hypertension, yes, we are all aware that hypertension does, the good control of hypertension, definitely the chance of diabetic retinopathy. I would not go into all these details. Lipids, yes, how control of lipids is very important. Dr. Amod Gupta from PGI Chandigarh has clearly shown how oral atorvastatin therapy in patients with type 2 diabetes with dyslipidemia reduces the severity of hard exudates and subfoveal lipid migration in CSME. So many of us do start these patients, especially when they are coming with extensive subretinal exudates in the macula, subfoveal exudates. It is important that you can start these patients on statins. Diabetic nephropathy and diabetic retinopathy, the subjects with microalbuminuria were around 2 times as likely to have diabetic retinopathy as those who do not have microalbuminuria, and the risk is almost 6 times in the presence of macroalbuminuria. Pregnancy and diabetes, because of the high levels of estrogen, human placental lactogen, there is a rapid progression of retinopathy, and they are likely to develop retinopathy and have progression over a period of time. So in women who begin pregnancy with no retinopathy, the risk of developing any retinopathy is about 10%. So they should be counseled regarding the effect of pregnancy on the retinopathy. All pregnant women with established diabetes should be screened in the first trimester of their pregnancy, and severe non-proliferative diabetic retinopathy or worse should be treated with scatter laser photocoagulation and stabilized prior to conception, because otherwise they can worsen to PDR, and controlling that at that point of time would become difficult. Anemia, again, patients with anemia were 1.8 times more likely to develop diabetic retinopathy than individuals with no anemia. And anemia can also lead to falsely low HbA1c levels, which may result in the undertreatment of hyperglycemia, so which could cause progression of retinopathy. I wouldn't go into the pathology of that. I was also wanted to touch upon this diabetic retinopathy and cardiac function. Coronary artery bypass surgery is definitely the preferred strategy for patients who develop multivessel coronary artery disease. But the presence of retinopathy is seen as a strong independent risk factor for all-cause mortality after CAPG. That is, the 12-year overall survival rate was 40% for diabetics with retinopathy, while compared with those without any diabetic retinopathy was 88%. We did a study at Arvind, and we found when we followed those patients who were going for a CAPG, those who had any retinopathy prior, before they had the CAPG, they had a higher risk of advanced mortality, while compared to those who never had any baseline retinopathy before. So this is clearly a very easy test that they can get to do. The presence and severity of diabetic retinopathy may be considered as a predictor of adverse cardiac events after CAPG, and simple ophthalmic fundus evaluation will help to prognosticate in these patients. But in clinical practice, do patients monitor their metabolic status regularly? Do we insist as ophthalmologists, do we have any way of following up these patients whom we are treating for retinopathy, and how often the systemic status and the ocular status and response to treatment is correlated over time? We are very happy when we treat the patient with the injections or the lasers and the edema goes away, but do we correlate it every time on the importance of using or evaluating the systemic parameters? I think that's something as ophthalmologists we need to follow up on this. Thank you.
Tim, actually this is very, very important aspect in management of diabetic retinopathy, that most of the time we criticize others, other specialists, that they don't take care of the eye, the retinopathy part of it. But most of the systemic parameters also need to be taken care of. And he has nicely highlighted different parameters that need to be concentrated on. But I ask you, Kim, at what stage would you say that I will counsel this patient for systemic control, very strict control?
No, over a period of, first of all, we do not have a baseline systemic status. Very often, if you look at it, Do we take the HbA1c when the patient comes? For every patient, even those who do not have any retinopathy, when they are presenting, we would say, oh, you don't have anything, go ahead and control, or talk to your diabetologist. So that is something, I think it is something that we
need to
have
be
to
changed.
follow on a regular basis.
That is what is required. Even if there is no diabetic retinopathy, get all the parameters he has mentioned, and you see if there is any derangement, try to control by sending the patient to that particular specialist. That is enough. After that, the patient will also be careful and he will control. Primary control is very, very effective. Of course, if they are deranged, secondary control is also effective, but primary control is much more effective. And I have another question regarding pregnancy. During pregnancy, if there is a center involving diabetic macular edema and injections are required, what would you advise?
I would probably do laser if possible, micropulse or is there. That would be the first choice of treatment if possible. Otherwise, go for the steroid.
Yeah, I think I agree.
Yeah.
So if DME is present in the early pregnancy, you can think of laser. Steroids can be given, though there are some evidence of early teratogenic changes in early pregnancy, but you can think of. But if it's in the late pregnancy, no need to treat.
Yes.
Because after delivery, it will automatically improve. So no need to be in a hurry to treat if it comes in the last trimester.
That is the key. See, initial pregnancy and late pregnancy is very, very important. Late pregnancy, you should differ actually. And most of the anti-VEGF agents are going to absorb systemically and they can affect the fetus. So we should differ that. Steroids and lasers are less harmful, so you can prefer.